Thank you very much. Hello, good morning. So I got a bit of nostalgia driving down Lovely Lane this morning because I used to be an SHO here a long time ago. And remarkably, even though this building is sort of old and was clearly here when I was here, I was never in it. I think that reflects SHO too busy to be sort of getting educated then. We just had to do everything experientially. Anyway, sort of since then, I trained in adult medicine, clearly, and that's why I did jobs here and in Manchester. And then I moved into this specialty called clinical genetics, which I didn't know anything really about at that stage. I was sort of under the impression that geneticists saw babies with birth problems, with congenital birth defects. And it was just at that time a new training scheme came in. It's called the Kalman training scheme, which was sort of a structured way of teaching or training doctors to get to a consultant. And they created the first Kalman jobs in the country in genetics. So you were a registrar and then you did your few years in training. I was lucky enough to get one of those in Manchester. So I got the first Kalman job in the country in Manchester. And I was the first person that had come into genetics who hadn't come in from a pediatric background, because it was sort of this realization that there were lots of older people presenting with inherited conditions, be they inherited heart conditions or different neurological conditions. And the changes I've seen over the last 25 years have been fairly remarkable. And I want to probably just give a little bit of a flavour of some of those and where we're at now and what this genomic alliance is. I mean, it's even, we're using different words now. We never used the word genomic then. Everything's genomics now, whereas before it was just genetics. And I don't think it makes much difference. We end up getting ourselves wrapped up in some of this terminology. But words are really important, and how you use words and how you use language with patients is really important. And some of the words that we use to describe conditions and to talk to people about their health that we would have used 20, 30 years ago, just not seen as being appropriate or acceptable, and can be seen as quite derogatory. And we have to be quite careful to make sure that we're using the right language. So we'll all have heard probably about 10 years ago, there was this huge initiative. It was linked to the Olympics, and David Cameron, this personal experience of having a son with this incredibly rare form of epilepsy. And Ivan underwent genetic testing, a new type of genetic testing at that time called whole genome sequencing, to find the reason why he had been affected by this very, very rare inherited condition. It was a condition which wasn't present, obviously, in his mum or dad, and had occurred as a completely new genetic condition in him. And of course, all genetic conditions have to start somewhere. We always think we're inheriting half our genes from our mum and half our genes from our dad, and that's true. But every single one of us has got a few unique changes in our genetic code that isn't present in our mum, isn't present in our dad. Most of those make no difference whatsoever. But if one of them lands right in the gene that causes a developmental problem, then you can get a new condition coming to life, and that's what happened there. And part of that experience gave him the sense that, gosh, this is new technology. Why isn't this available to lots of parents and other people in our situation? Can it be used in other situations, like determining causes and response to infectious diseases? Can it be useful in determining the right treatment for people with cancer? So that's where the 100,000 Genomes Project came to light, where there was this introduction of whole genome sequencing. There's been a number of challenges around that, but essentially it's a remarkable technology. You know that in 2001-2, it was that Bill Clinton and Tony Blair were on the White House lawn saying the whole human genome has been sequenced. Well, it hadn't quite all been sequenced then, but that was one person over 15 years, and it cost about $3 billion. Now we can order a whole genome test in our clinic for a patient, dependent on the clinical scenario. You can get, there are challenges in the laboratory, but you can, in theory, get a result back in 2 to 3 weeks, and the cost of that is around £1,000. within the NHS. If you do this at scale, where you're doing thousands of these, just in a laboratory like the Sanger Centre or the Broad Institute in America, you're doing it for less than £100 a person. It's truly remarkable, the scale of it, and the speed and change of technology. And that's all interesting enough, but one of the key things is, how do we use it? How do we make sure that this new technology is relevant for patients and we can use it in a meaningful way? So the 100,000 Genomes project finished in 2018. There's been sort of various outputs from that saying, is it a good thing using whole genome sequencing? Is it living up to its promise? What are the added value of it? One of the things that then emerged from that was the fact that we needed to structure our laboratories more effectively around the country. So in the Northwest, we've got a major genetics laboratory based in Manchester, which links across to one in Liverpool, then with small outposts at the Christie Hospital in Manchester as well, doing some cancer work. And then there was also, as you know, there's clinical genetic services. So they're based in Liverpool for up along the coast and down to Cheshire, and then in Manchester, which goes up to sort of the South Lakes and down to Macclesfield. So the whole of the Northwest is covered with peripheral clinics, and Warrington sort of sits within the Liverpool conurbation. Although if you're on the west side of Warrington, you might get drawn into Manchester. So they're the clinical genetic services, and you've got the genetics laboratories. And then about 3 years ago, there's this concept that they wanted to create genomic medicine service alliances. So that's what I'm the clinical director of that alliance for the Northwest. So there are 7 regions in the country, and the purpose of these alliances isn't to see patients, but it's really to look at how we make sure that genomics is relevant, and what are the new things that are coming that we can make sure that they actually have a benefit for patients. So there's still lots of work to finish around the Genomes project. The Genomes project, if you read the newspaper or go on the internet, people say, oh, what a great success it was, isn't it wonderful? That 25 to 30% of people got a diagnosis through giving their samples to that project, which is a very positive thing. But that means that 70% of people didn't. And, a lot of those people have significant health problems, and it's a responsibility of us to go back and look at that data, see if there are different ways of analysing the data that we can get the answers. And that reanalysis approach, because there are new techniques, new computing ways of looking at the data, probably can increase the diagnostic yield by 10–15% at least. Without doing any more testing, you just look at the data in a different way. One of the things, if genomics is really going to be credible and going to make an impact for patients, it can't be reliant on people like me. There are only 200 clinical geneticists in the country. There are about 300 genetic counsellors. And if with a population somewhere between 60 and 70 million people, we're never going to get to see everyone, meet everyone, offer them what they need. So genetics has to be delivered by health professionals across the whole spectrum, from primary care, from GPs, pharmacists, into hospital-based medicine. But it hasn't to be based around, senior doctors. It has to be the nurses, the pharmacists, all those individuals that are having, midwives, the people that are having that face-to-face contact with patients. So over the last couple of years, we've been working on a number of individual projects to try to understand what we can do in genetics that we can do better, focusing on some of the needs of people in the Northwest. And that's been guided by our partnership board. So Mike Gregory is the Northwest NHS medical director, and you can see that we're trying to interact with lots of different groups across the Northwest, because we don't fundamentally want to just copy what other people are already doing. Cancer Alliances are doing lots of work. Cardiac networks are doing lots of work. We don't want to just be another voice in there. We want to see what added value we can contribute. And one of the things that's been right at the key, at the centre of what we've been doing, is thinking about those groups that haven't traditionally had access to genomic medicine, based on either where they live, because they might live more rurally, based on their socioeconomic backgrounds, or the pressures of getting to interact with health professionals because they're busy at work, or they're rushing around sorting out their family life, or because they feel concerned about genetics. They feel that it's not being used in the right way. There might be some cultural challenges there, and so making sure that the offer around genomics is relevant to everybody is something really important. So we've been working particularly with the Pakistani and Bangladeshi community, and going out to community events, going to the mosques, going to the cricket, and working with people as part of a project called Manchester Genes and Health. And the reason for that is, as you know, there's a very large South Asian population, particularly in central Manchester, North Manchester, up into East Lancashire. And they make up about 5% of the UK population. But the key thing is that the risk of cardiovascular disease is probably 4 times greater. The effect of COVID was much more severe in that population, much greater incidence of type 2 diabetes. And if you look at one of the really huge resources that we have in genetics, it's something called the UK Biobank. So there's loads of genetic data there. Go and look at, I can compare, when I'm looking at genetic test results, I can compare against that data set. And that's really, really valuable in helping us to interpret genetic information. One of the problems is that of the 500,000 people that took part, less than 3,000 were from South Asia. Only 2,000 Pakistani, 600 or so Bangladeshi origin. And so we've got no real comparison data. So we need to build up that resource. Plus, at the same time, looking to see why people from those communities are at higher risk of certain common conditions. So some of the projects that we've focused on at a national level have had leadership across Liverpool and across Manchester. I'm going to pick out one from this list, which is around sudden cardiac death. So this sort of brings home to me the fact that when I was working here, one of the SHOs, when I was on call one night, collapsed and died. He was only in his mid-20s, completely fit and well. And it was only years later that his family came to see one of my colleagues in the genetics department. And there was a complete shock, and couldn't understand why this young man had died. And when he was a medical student, you know, as medical students do, he had an ECG done. And it'd just been on his wall. And his parents brought it along and said, you know, I wonder, does this show anything? And it clearly showed that he had a Brugada pattern. No one had ever picked it up. It hadn't been picked up at medical school. It was just, oh, let's just all go for an ECG. And that family then were offered, a number of years down the line, some understanding of why this had happened, also offering screening to other people in the family. And when families get into see cardiologists or they get into see geneticists, they get a good service. They get an explanation. They have tests offered to them. They get support. But there's an understanding that a lot of families just weren't getting to our services. A lot of families just weren't being referred, and because it wasn't quite known what to do or how to do it. So we've been working with the coroners across the region and with the coroners officers, because the coroners officers are the people who actually are dealing with the families at that time when there's a sudden death, and making sure that the families have an explanation of why you might want to take a sample to store, and then so you can do genetic testing. And then you can refer the family to see their local cardiology service or their genetic service. And now that's happening in North Manchester. It's been opened up in Liverpool. We've just opened up in Blackburn, planning to open up in Blackpool. The plan is by the end of the year that that service linked into the coroner's team will be available across the whole Northwest. And no family will be will miss out. You know, some families decide that they don't want to take part and have any genetic testing. Sometimes at the time when you approach them, it's because everything's so raw. If you go back then to a few months, you know, then they think, oh, well, maybe we should look into what this could be for other members of our family. And so building up those relationships is really important. We've had a number of small local projects. So the one I've just described is a national project that's been rolled out across the whole country. But we've had some local projects. And to give an example of that, we've worked with, in Liverpool, the Alkaptonuria Centre. It's a national centre for a vanishingly rare condition which can cause arthritis and other health problems. People get sent from all over the country to that particular centre. But actually, what we wanted to do was to try and ensure that people, if you live down in the West Country or across in, East Anglia, that you'd get access to genetic testing. You wouldn't need to have to come to Liverpool to have all of that done. So providing that information so it was local and relevant to people was something we thought was helpful. This year, we've focused on some projects which I think are really have been important, looking at how we provide better services. So one has been around looked after children. So these are children that are in care either now or have been in care in the past, who may not know anything about their biological family. And then they're thinking of having children themselves, and they want to know, are there things that they should be thinking about in terms of what risks that they might have in terms of having a family, or if they've got health problems themselves, what tests might be appropriate to look into that in a little bit more detail. So that is a project that we work very closely with social workers, and a number of the things that we're doing is realizing that there are a number of other people involved in the care and support of families, and you need to link in with all of those individuals. So I'm going to give an example of a project that we've been involved with. So this is a Manchester-Liverpool project where we've known for about 30 years that people with a specific genetic change, a change in what's called their mitochondrial DNA. So that's the DNA that's just inherited from your mother, okay? And individuals with a change in that mitochondrial DNA, if they're given a very common antibiotic called gentamicin, 1 in 500 of them will go deaf, and that will be irreversible. So if you've got a diagnosis of something like cystic fibrosis, at some point in your life, you will get gentamicin or another aminoglycoside antibiotic. So we can do the genetic test, and then we can give appropriate advice about which antibiotic is safe. But the different situation is if you have a newborn baby's taken to special care baby unit. Standard criteria for the NHS from NICE is that within an hour of them arriving on the unit, they should be given antibiotics, penicillin and gentamicin. So a genetic test, as you know, at the best takes 2 or 3 days, maybe even a bit longer, even to look for a single genetic change. So that doesn't work. So what we wanted to do was, could we do a test quickly at the bedside that gets that result that we could then inform that genetic testing? So we worked with a company in Manchester called GeneDrive to develop a specific test. We ran a study in the Liverpool Women's and at St Mary's in Manchester. This is the first time this has been done anywhere in the world. And what we did was 750 babies. We tested them consecutively as they came in. The standard time to take that swab as the baby came in was 6 minutes. We looked at how long it took for the antibiotic to be given to the baby before we did any testing, and during the study when we did the testing, and we saw there was no difference. It was 55 minutes, so it was within that golden hour that you have to do the testing. And out of those 750 babies, 3 of them had the genetic change. We were able to give them a different antibiotic, and now this testing is sort of started to be rolled out. And the reason for that is because you think, well, it's a new test. It all sounds, a bit expensive, a bit fancy. And there is a cost to any new intervention. So there will be a charge for the neonatal units for this. But if you compare that to the cost of cochlear implantation for these children with profound deafness, there's probably a saving of somewhere between £5 and £7 million a year for the NHS. And if you scale that up across the world, there's probably about 7 million babies every year in the world given gentamicin. So that's 14,000 babies every year you can stop going deaf if you just introduce this type of testing. So what we're keen to do is to try to provide real life examples. We don't want genetics to be seen as something that's remote, something that's not relevant, something that only affects a tiny number of people. Rare conditions affect about the definition is that a rare condition affects 1 in 2,000 people. There are at least 7,000, there are probably double that number of rare conditions. So it's estimated in the UK there are 3.5 million people that are affected by a rare condition. So this is a huge burden of disease. And if you go into the Children's Hospital in Manchester, it's probably the same at Alder Hey. About a quarter of all the children that are in a bed at any one time have a rare inherited condition, because these are conditions that have a huge effect and sort of are chronic. And what we're finding now is with some of the huge, wonderful advances with treatment, those children are now living longer, living full lives, but there are a number of long-term studies we need to do to see what the effects of the treatments are, what it's like to live long-term with those conditions, what the complications are. So we're seeing a whole new cohort of people living with genetic conditions and needing to offer services and needing to understand how genetics can impact on their care. So that's all I've got to say. There's plenty of other things and topics that I've not covered, but hopefully through the course of the day, you'll get a bit of a flavour, or through the morning rather, you'll get a bit of a flavour of some of the things that are happening in genetics, you know, at a regional and a national level. Right, so am I going to, I don't know if it's Simon up next, is that right? Yeah, I'm happy to answer any questions, if anyone's got any questions. If not, Simon, oh yes, okay.
Yeah, we don't use gentamicin for our neonates. We're pediatricians, we've always used cefotaxime and amoxicillin because of the danger of gentamicin. So, but how are you going to roll out the kits to peripheral hospitals?
Yeah, so that's a great point. So one of the concerns has been, you know, so what we've wanted to do is to try to encourage everyone to be in a position to offer gentamicin. The rollout is complicated in that commissioning within the NHS is complicated. And even though the health economics all stacks up, everyone turns around whenever, you know, we've published, you know, papers on this, we've been given awards on this, and everyone says, this is great, we should just do it. Okay, well, let's do it then. Oh, it's a bit complicated, there's a meeting, there's a, you know, this sort of stuff, that sort of stuff. So working out the commissioning is challenging. We're working with the AHSNs in Manchester and Liverpool, and they're working on a rollout program. So in the short term, we're going to go for a regional rollout. We're having national conversations. We've had them with the genomics commissioners. I think it's more likely that this is going to be commissioned through the neonatal services, through their CRG. We're having conversations with them. One of the challenges, as you're aware, is I described where the savings are. The savings are in cochlear implants. You turn around to the paediatric ENT team, say we want to take £8 million off your annual budget. They're not going to tolerate that. And so we've got to, because it's going to take a while before they see the benefits and less children coming through with the need for cochlear implantation. So in some ways, the science has been the easy bit. That we've been pleased that there's been a nice assessment of this, and which has been very favourable. The only thing that NICE have asked us to do and to provide a little bit more evidence is that what we demonstrated at St Mary's and Liverpool Women's, that this can essentially happen in smaller units, that it's not just because there are loads of staff around and you've got, you know, resources that you can do this, but that this should just be able to be incorporated routinely. The other thing that they wanted to see from us, that this testing was relevant across all ethnic groups, and we've been able to provide them with the data to show that of the babies that were tested in Manchester, over 50% were non-white. And so that's given them that evidence. So we're working with the HSNs for that rollout, and we'd hope very soon that we'll get sort of some sort of national guidance that then we can help to roll this out. Very good. Simon, it's all yours. Let me get rid of that. Oh, I think, does it just naturally roll on? You've made a full day. Oh, brilliant. There we go. Thank you.
My name's Simon. I'm the renal registrar at the Royal Liverpool Hospital, and I've been over the last 10 months been working with one of my consultants, Dr. Howard, from Royal Liverpool, and Dr. McCann, from the geneticist at Liverpool Women's Hospital, who has now moved away. But we've been trying to develop a renal genetic service at Liverpool Royal Hospital. So I'm going to talk about what we were doing prior to me taking the post in our current project, what we have been doing as a part of the service development project, and show you some cases and some data, and then what we hope for in the future. So my current role is a clinical fellow post in subspecialty nephrology, and after talking to my consultants, I've taken up my main focus being on renal genomics, with the aim to expand the links between nephrology and the geneticists at the Liverpool Women's Hospital to develop a functional renal genetics service at Liverpool Royal. And that's obviously needing to develop my own knowledge on genetics from so I can develop the service and educate my colleagues on how we can utilise genetics within our patient cohorts. And I've also joined the North West Kidney Network Renal Genomics project to try and help develop the service regionally over the past year. So in the past, genetic testing within our department was just referred to the geneticist. We were doing very minimal genetic testing, mainly only on cystic kidney disease patients in our polycystic kidney disease clinic. We've had a monthly renal genetics MDC, which we've been running for the past year. But there's lots of problems with that, with no documentation of any discussion, any results, leading to referrals not happening, tests not being arranged, and cases being repeated multiple times to the MDT. And these reliance on the genetics team to see all our patients left some patients either not having access to genetic testing or long waits in getting to an appointment. So as part of the North West Kidney Project, we assessed that there was some variability in pathways and access for patients across the region, and identified awareness and equitable access to genomic testing was an area of need. We had a funding from approved from the GMSA to develop the regional service, and issues were in current practice were identified that we tried to address with the aim to produce a robust pathway for all North West Kidney patients and integrate and embed them within genetic testing into pathways across the North West. So while inherited kidney diseases are rare, collectively they represent a fifth most common cause of end-stage renal disease, accounts for somewhere between 5 to 10% of end-stage renal disease in Europe. There's approximately 200 rare disorders known to involve the renal system, the vast majority of these having a genetic basis. And despite this, the genetic testing is underutilised across the board. There has been some studies in Europe with Groupman identified the genetic diagnosis in 10% of individuals within an unselected cohort of 3,000 adults with chronic kidney disease. And a more recent study from published this year, it's highlighted it took 476 patients and found that 67% had a genetic diagnosis, including 70% of adult patients. So there's been increasing accessibility to genetic testing for renal patients, and we follow the National Genomic Test Directory, and we're aiming to move away from the select few people having access to genetic testing to increasing their genetic testing for renal patients. And we're looking at there's a paradigm shift from just the select few getting genetic testing and having access to this advice to medical specialties, including ourselves, undertaking the responsibility of identifying these patients and undertaking the testing. So how can we utilise genetic testing within renal? So it could aid in diagnostics. It can help these identify cause for patients who have been on a long diagnostic journey, who have a very rare condition, and it can help get them answers to why they have their condition. It can help us with prognosticating their renal disease and help with planning for dialysis, but also transplantation. We know that the best outcome and best treatments for kidney failure is a live donor kidney transplant. So identifying patients who have a genetic cause for their renal disease is then useful to diagnosis, and then also screening of family members, because the majority of our live donors have a kidney donated from a relative. So we can then screen family members to ensure that they don't have that condition and making it safer to transplant those kidneys. It can help guide our management. So we've had lots of our patients with glomerulonephritis need immunosuppression, and if we identify a genetic cause for that, it means we can stop immunosuppression in those patients and not exposing them to quite serious adverse effects from being on these medications. It can avoid the need for invasive tests, such as renal biopsies, and personalised medicine. So it's rather than this one standardising of management across the board for these patients with a certain condition. We can actually screen for extra-renal manifestations and complications, and now allows access to genetic counsellors and family planning. So at the start of our project, we undertook a renal genomic awareness survey, which was a survey sent out to all the renal consultants, adult and paediatric, in the Northwest, and to our registrars and specialist nurses. And so assess the awareness of genetic testing and the barriers to arranging testing, and how we can use that to develop our service. So we had 40 respondents. The majority of those were consultants, adult consultants, 25 adult consultants, 4 paediatric consultants, 11 are trainees, and 3 were nurse specialists, renal nurse specialists. The majority of those response came from Cheshire and Merseyside, and we assessed how they were doing testing, and there's about nearly a third of patients had never done any genetic testing in any of their patients. And when we compared those results across the professional groups, we can see here in orange the adult consultants, and then in the blue the paediatric consultants. The few paediatric consultants who did respond to the survey, they were doing testing more frequently, whereas the adult consultants were either doing it yearly or had never done any testing. The most common reasons for doing testing are, as you'd expect, cystic kidney disease or alcohol, so the most common causes of inherited kidney conditions. But there's a number of other indications that testing will be performed, which align with the testing directory. So when we assess why testing wasn't being done, it was about 50-50 people. 50% were confident in identifying patients, but as that process going through identifying patient, consenting a patient, undertaking the testing, interpreting results, as that pathway goes through, more and more people weren't confident in undertaking testing for those specific reasons. And when we compared those across the board, across the professional groups, again, in the adult services, we demonstrated that we weren't as confident in identifying, ordering and interpreting results compared to our paediatric colleagues. We analysed if people had access to a genetic testing pathway, and more than half of people didn't know they had didn't know if there was a genetic testing pathway in the region. About a third didn't know how to get advice for genetic testing, and nearly half didn't even have access to the genetics MDT, and the majority of patients didn't have access to a renal genetics clinic. More than half, so 2/3, didn't even know that the genetic testing directory existed, and the majority of them obviously hadn't even accessed the testing directory. When we looked at how we could, what were the specific barriers to getting genetic testing, ordering the testing, accessing genetics experts, and interpreting results were the most common barriers that people were experiencing, as well as not having adequate time in the clinics. And it was deemed that having access to geneticists and genetic counsellors, improving the ordering process, and potentially having a renal genetics clinic was deemed desirable. So we already had a polycystic kidney disease clinic within the Royal Liverpool. We started doing testing in this in the PKD clinic, one because we had access to a cohort of patients we knew had an inherited kidney disease. The aim wasn't for blanket screening of these patients, and we'd get good numbers that we're confirming a genetic diagnosis, and we're aiming to select the patients who would benefit from genetic testing and alter their management. But we were also inviting patients who referred to us who didn't have polycystic kidney disease to come to the clinic, and we could do testing on them for other indications as well. And this clinic allowed extra time in the clinic. We had longer consultations, and we could undertake testing and consenting and discussing the diagnosis of these patients in these clinics. And this addressed numerous aspects that were concerns on our survey. So we developed a pathway at Liverpool, which again addressed numerous issues with accessing genetics specialists or the MDT or referral to the genetics clinic, so it's clearly signposted how you can access these services. We have an IT system that would refer to the appropriate person, as previously it was just a referral by email, and these were getting lost and weren't always happening. And we had the renal genetics MDC, which has been going for a few years, and previously it was just an email referral, but the referrers weren't attending these MDTs after referral, so it was having sort of a meaningless conversation, not having a clear outline of what the clinical history was and the outcomes of these MDTs wasn't great. So we've tried to encourage the referrers to attend these meetings to try and improve the outcomes of these MDTs. So we've now developed, we have another IT system which is clearly documenting the outcomes of the MDT or the reason for the outcomes of the MDT and outcomes of the testing, and also this for having access specifically to all the request forms and consent forms, record discussion forms, so the signposting so where we get these, how we call it tests. Well, we plan to move this genomics MDT to another platform which will be starting next month, which is called Patient Pass, which is allows a two-way communication between the referrer and the geneticist who's reviewing the referral, so we can make sure that when we're discussing MDT, that we'll have all the relevant information, and it will allow us to create an MDT list that will inform the referrer that they need to attend, and create a report that is sent out to each referrer with the actual documented plan for the MDT, and has a full audit trail of all the discussions. So we moved from our polycystic kidney disease clinic, where we're doing some genetic testing. It was impacting on the patient care in the polycystic kidney disease clinic with our management of certain, we're managing our patients with tolvaptan therapy. So we've created a new genetics clinic since then, where we have on Thursday morning every month, where I am seeing patients with genetic testing. We're seeing 3 patients in the clinic, which gives me an hour's time, which I believe is the same to the genetics SBI will see in their clinic, an hour's to have a discussion with the patient, discuss their potential condition, consenting the patient, and just looking at the patient that was tested. Once these patients are seen in our clinic, they go back to their parent team, and then once we get the results, we bring them back to the clinic to discuss those genetic testing. We've also had funding from the North West Kidney Project for a renal genetics nurse specialist. We've identified a colleague who's going to hopefully take that post up in the next 1 to 2 months. She's currently the tuberous sclerosis specialist nurse within the trust, and we feel that combining that with a genetics nurse specialist and this complex nature of both genetic conditions and the TS with its genetic basis will complement each other well. And we're hoping that they'll be able to help us with this, speaking to patients, obtaining family histories and pedigrees, seeing patients in the clinic as well to go through the consent process, and hopefully organising our MDT and chasing results for us. So when are we to consider genetic testing? So some of them are quite obvious, obviously the family history of kidney disease, then we need to consider that. If there's any resistance to treatment, then we can think, is there something else going on that could be contributing to this? Is there any extra renal involvement, any congenital abnormalities, any cysts on the kidney that could represent cystic kidney disease, any younger age of presentation, and if there's any unexplained end-stage renal disease under 35 years, and if you're planning live donor kidney transplantation as a possible genetic cause. So very quickly, just a few cases if I've got time. So first of all, we've got a 25-year-old female who's had polycystic kidney disease. So these are patients who've done genetic testing, and she's got family history, extensive family history of polycystic kidney disease, and multiple family members. And she clearly has a diagnosis of autosomal dominant polycystic kidney disease and confirmed on ultrasound scan. And we don't need to do a genetic testing in her. We have a firm diagnosis, but she came to us asking about family planning advice about what her options were. And obviously, there's a 50% chance of passing on this affected gene to her children. And we did genetic testing so she could refer to the family planning team for consideration of pre-implantation genetic testing. And There is also in polycystic kidney disease, it may change in the future. There is some scoring systems that combines genetic diagnosis and clinical features that give you a higher, lower risk for developing end-stage renal disease. And it may be that we use this more and more in the future with treating our polycystic kidney disease patients with tolbactam. The second case, we had a 28-year-old male who'd had a diagnosis of Alport syndrome. He'd had previous transplants and been on dialysis, was now back on dialysis. And he had some genetic testing, which hopefully is anonymized completely there, that's confirmed it's autosomal recessive Alport's disease. And he's been worked up for a second live donor transplant, and his sister was hoping to donate a kidney. She had good function and was very well herself. But we did genetic testing on her, which showed she's a carrier for the same gene. And we had to have a review of our the literature and discussions around MDT. Although she was very well, no normal renal function and no proteinuria, there was a small risk that she could have develop kidney disease in the future, and that's increased with issues to donate a kidney. So the decision came that she did not donate a kidney, and then that was guiding our management of both patients, the donor, the potential donor, and the recipients, and having to look for a kidney elsewhere. And another case, a 47-year-old male who had CKD was referred to as a declining function of proteinuria. 6 months of each part dropped from 64 to 46. That's significant proteinuria. His brother had a biopsy a couple of years before, showed FSGS and did not respond to immunosuppression and was being worked up for a transplant. And we discussed him in our biopsy MDT, so which had given his history and his family history, decided not to biopsy, and we avoided invasive, well, at the moment, we avoided invasive procedures, and we've gone down the line of a genetic diagnosis first, and we're awaiting genetic testing results. But that could potentially avoid him having to have a renal biopsy. So how I'm doing time. Again.
One more.
Yeah, I'll go down that. We'll do it today. So, what have we been doing so far at Liverpool? So those are some of the examples of what we're doing next testing. Show that the impact on our doing genetic testing is already had on our patients, even though we've been going on for 10 months, and it's still very much small scale. This is our dashboard, that form that we showed earlier, where we're entering our MDT forms. It's linked to our dashboard and gives us live auditing and demonstrating of what we're doing. So we can see here that on the that we have doing the number of our testing is increasing. We've done 30 tests, so mostly doing whole genome sequencing, which has been with cystic kidney disease and for unexplained end-stage renal disease. But we're also doing testing, panel testing, or single gene testing for a number of indications, the hematuria, steroid-resistant nephrotic syndrome, APEPS. And so there's a broad range of indications we're testing, and predominantly at the moment it's showing that we're doing testing of cystic kidney disease, because that's where we started that clinic. But the referrals now are more reflective of other conditions, and that middle chart there will start to even out as we're doing testing for other indications now, as we get developing experience within the genetic testing. The dashboard also shows who we're doing testing on, and the majority of our patients are aged between 20 and 50, but we are still seeing indications to do testing even in older patients, but obviously less frequently. We're also looking at when we're ensuring, seeing who we're testing. We've looked at the demographics, the ethnic background, and also looking at equitable access. We're looking at where we're doing testing for postcodes, and also on deprivation score as well. So are we picking up the right patients? So we've identified on the results that we've got so far, 16 have shown that we've identified a mutation that explains patient's clinical condition, and 4 have shown no mutation that's identified in the presentation. And so we've done quite a lot more testing over the last few months, so these numbers of results will increase soon. The importance is, although 4 of these patients we've not identified a mutation, it's still informing our results. The next results is guiding our management. So one of the cases that I skipped through before was a patient with steroid-resistant nephrotic syndrome who we had tried 4 different immunosuppression, had no But before we escalated that immunosuppression even further, we did some genetic testing to rule out genetic cause. And if we had to identify genetic cause, we would have been drawing immunosuppression and avoiding exposing these to these medications with serious side effects. So, future, we've demonstrated that we can do genetic testing in a small genetic clinic at the Royal Liverpool, but we're going to continue that ongoing monthly renal clinic. We're going to be appointing a renal genetics nurse specialist in the next couple of months, and we'll continue to build links and collaborative work with the genetics team at Liverpool Women's Hospital. To continue to collect our data to measure success of the clinic and to build long-term business case for a renal genomic service, and whether we can build that onto a renal genetic MDC clinic with a nephrologist, a geneticist, or a genetic counsellor in place with our specialist nurse as well. Similar to what we've already achieved with our tuberous sclerosis clinic. So just to summarise, we've demonstrated that there's indications for testing in our renal patients. We've demonstrated that we can create a pathway to access these testing for our patients, and we can organise these on a small scale. Already, we have resources required to scale this even further.
So years ago, before genetic testing became sort of commonly available for polycystic kidney disease, we were always told that there's no point undertaking scans, ultrasound scans in children. You'd wait till people are a bit older, then you pick up some cysts, and if somebody had no cysts by the age of 30, then that's fine, off you go. With genetic testing now, do you find that parents are wanting their children to undergo genetic testing at a younger age to clarify whether they're at risk or not? And if you find that they do carry the familial genetic change that puts them at risk of developing polycystic kidney disease, is there anything, apart from keeping a check on their blood pressure, is there anything that you can do to intervene to sort of slow the progression or sort of change their clinical management?
I think it's the opposite. In fact, when we're telling these parents that that used to have very young children, then they're in agreement. They're in agreement that we don't try and, if they're well, ask them to do their blood pressure, the urine, and if they're okay at that time, then not medicalising them at such a young age and just making them aware when they get to 18, 19, whenever they feel appropriate, they need to get tested. I need to get the appropriate screening, whether that's genetic testing or just the ultrasound scan and blood pressure checks, and explain to them as they get older the symptoms may develop. I have the opposite finding so far is the agreement that if they're well, blood pressure is okay, the urine is clear, we're not medicalising these patients so young, and that we ensure that they're followed up when they get to late teens, early 20s.
Yeah, so you're allowing the child to be able to make that decision themselves as to when they're 18, whatever.
Yeah, so now the parents make that decision.
Yeah.
Then when they get 18, 19, as long as the child, adult then, makes an informed decision themselves.
Yeah, perfect. Thank you. That's interesting.
It was really interesting, expansive piece of work. Well done. It was actually quite impressive. It looks like you're expanding and diversifying your staff base a little bit, and anyone in mainstream is also looking at the same thing. So where did the funding for your advanced nursing colleagues come from?
So we, via the Northwest Kidney Project, we had a funding for half a day for the renal genetic specialist nurse. We also had an extra half a day a week funding for an MD2 order. We could combine the post. We also already had a funding for a couple of days a week doing a TS nurse specialist, and now we're in the process of applying to bridge that gap for the extra day so she has that she will have a TS.
That's a long term.
That's a year. So for the renal genetic specialist nurse, it's a year. So hence why we need to collect our data to build a business case and just apply further applications in the future for a long term post.
Thanks very much, Sam.
Sabnam. I'm a diabetes consultant and I'm the GMSA lead for the Genomics Diabetes bit of the national NHS Newman strategy. So I'm an adult clinician, and the last time I did this, it became apparent that everyone here is not an adult clinician. It's just so I know what it is. Who here is a pediatrician? Just put your hand. Who here is a geneticist? Put your hand up. And who is an adult clinician? Some people have not put their hands up. Let's repeat that. Okay. So I'm currently a diabetes consultant. I'm based at Aintree Hospital, and I slightly fell into this by accident. I'm the Northwest GMSA Moda lead, and the GMSA is appointed lead for lots of different areas. When the NHS England strategy was launched in 2020, I got coerced is a strong word, but it felt like that at the time, involved in this because I happen to refer a lot for monogenic diabetes. But the reason I do that is because I wasn't trained in the northwest of England. So I was a registrar in the southwest of England, where managing people with monogenic diabetes is really embedded in standard diabetes care. It is not embedded, it isn't embedded in northwest care, and it definitely wasn't at the time I came, because the management of monogenic diabetes was somewhat haphazard. So monogenic diabetes, which I'll explain in a bit more detail, only became a thing about 15 years ago when it became easier to test for and more was known about the different genetic subtypes. And a lot of this work was done in Exeter, and it's still one of the international centres, probably the international centre for diagnosing and managing monogenic diabetes. And their strategy was that they would fund specialist nurses across the country if you could identify a nurse who was interested. That's really haphazard, and for many years the Northwest didn't have a nurse, and the nurse's role was, if you thought monogenic diabetes was in your future, you talk to your specialist nurse about what you think it might be, what testing you need to do, how their treatment would change. But our region didn't have one. But then in 2020, NHS England got very interested in genomic diseases, as it probably should do, identifying lots of diseases, which you'll have heard about already today, that are relatively easy to test for. There's a recognised way of testing for them, and they have a treatment pathway that's recognisable. And this is definitely true for monogenic diabetes. For lots of subtypes, they're very easy to test for, and they're also easy to treat. But we were nationally and definitely regionally underdiagnosing it. So monogenic diabetes are all mainly autosomal dominantly inherited forms of diabetes. All forms of diabetes are relatively easy to recognise in that the patient has either a high blood glucose or a high HbA1c blood test. So my best description of monogenic diabetes is that they are existing in your diabetic population, but they're very slightly different. So it's like trying to find a needle in a large pile. Diabetes is common, and monogenic diabetes is uncommon. It's supposed to represent roughly between 1% and 5% of your general diabetic population. So amongst this morass of patients we have, we need to find these people. But essentially, they respond to standard treatments, usually insulin. But if you can diagnose them with monogenic diabetes, it has 2 or 3 really important implications for the patient. The first is that lots of them can be managed off insulin, which is a massive change to the patient's life. Not having to take insulin is your holiday insurance will drop, your life insurance will drop. You can join the army. You can drive on a standard driving license. So from a patient point of view, it's a really good thing. And insulin is slightly complicated to manage. From a family point of view, they are autosomally dominantly inherited. So if one family member has a monogenic diabetes form, other family members are likely to have it. And the inheritance pattern is so strong, it is useful to know that, particularly when family members are pregnant, as some of these can cause problems in pregnancy. And then the third reason it's useful to diagnose is that these people feel, when they're diagnosed, probably initially with type 1 or type 2 diabetes, that their treatment is not quite right. The rules that apply to other people with diabetes don't quite apply to them. So getting a diagnosis and getting onto the right treatment is obviously satisfying as a clinician, but really, really important for the patient. So even amongst the diabetes healthcare professional community, monogenic diabetes is a little bit confusing. People get confused. So the best way to think about it is diabetes is not type 1 or type 2. So type 1 diabetes was first described 1500 before Christ by an Egyptian guy who noticed that people were peeing a lot. They were becoming emaciated. This is because they didn't have insulin, or they didn't know about insulin then. And after a short period of time, they died. And that is a really accurate description of type 1 diabetes. And up until insulin was isolated, just 101 years ago this year, everyone with type 1 diabetes would die after a short period. The quoted life expectancy in the 1920s was between 3 and 6 months. So that's type 1 diabetes. From a genetics point of view, it's not a monogenic condition. It's not inherited autosomal dominantly. It is genetically to certain HLA groups, but they are quite varied. So the testing, predictive testing for type 1 diabetes is a bit haphazard, and it's not strongly inherited. So we kind of don't think of it as a genetic condition. It's thought of as an autoimmune condition. Type 2 diabetes was first described 500 years after the birth of Christ, mainly in India and China. So physicians in India and China about 1500 years ago described this condition of older, overweight people who peed a lot, got leg ulcers, bimbled along for 5 or 6 years and then died. But they weren't emaciated and they didn't become critically unwell. And that's quite a good description of type 2 diabetes. So these are the main two types that most people here will have heard of. However, in the early 20th century, some physicians started noticing people with diabetes who were not behaving in those two classical patterns. They were usually younger patients, so not like the older patients with type 2, so they were young, but they didn't become exceptionally unwell. And this led to its name, maturity onset diabetes of the young. So the maturity onset bit comes from how it appeared in the patients. It appears in an insidious way. They weren't critically unwell, they didn't become emaciated, but they were young. So it's like a mishmash of type 1 and type 2, and that's where the term MODY comes from. The other thing that these early clinicians noted in the early 1900s was that there was a very, very strong family history of inheritance of diabetes, or something that we look at. Because type 1 and type 2 aren't strongly inherited, adult diabetes nurses and doctors don't take family histories very well or effectively. But in the early 1900s, people tended to do it because it was a useful thing to work out what was going on. So this is a page of the BMJ from 1928, which is the first published description of monogenic diabetes. This is blown up, so I'm just going to go back. In the middle is someone describing VF, I think, for the first time. So this is where medicine was in the 1920s and 30s. New ECG machines and weird diabetes. And Hamich talks about how this odd form of diabetes doesn't look like type 1, doesn't look like type 2, very strongly inherited in families. So this is the family that he describes. They're very early 20th century, early 1900s. They're all these siblings, and the numbers on them are the ages at which they're diagnosed with diabetes. In the 1970s, so this sort of gets left alone, insulin gets discovered, people get very excited about managing type 1 diabetes, and we kind of forget about this story. So this is from another paper in the 1970s. So this is when they start thinking about monogenic diabetes in a bit more detail, and that it is going to have a genetic basis, and people start looking for genes, mainly in the 90s, but it stems from this article that a man called Tattersall wrote, where he describes a family with diabetes. So this is one family in I think it's either the late 1950s or early 1960s. The numbers over the people are the ages at which they're diagnosed. It happens to be all women in this family. Men can get it as well. There's no sex differential. It tends to be noticed in women more because they get their bloods tested a lot when they're pregnant and their urine tested a lot. They're not twins, the 9-year-olds, they're cousins, although they're dressed up like twins. And so the bride, one of these is her sister, one of these is her niece. That is the bride's mother. We think that's the grandmother who was diagnosed at age 23, but the grandmother is one of these girls. This is all one family. The odd thing about this is she is alive 40 to 50 years after the diagnosis of diabetes, which was unusual then because treatment was so bad. So it kind of demonstrates a few of the key factors of monogenic diabetes. One is a very strong family inheritance pattern. The second is you tend to be younger when you're diagnosed. And the third is you do better than expected for type 1 or type 2 diabetes at this time. And they're kind of three key features of monogenic diabetes. This is directly from Tansol's article. He describes diabetes diagnosed in the teens or early 20s. It's mild and doesn't progress to insulin dependence, even over a period of 40 years. That is unusual. He describes the Mendelian dominant inheritance pattern. And because he looked at a really big family, you could work out that it was autosomal dominant. Complications are uncommon and mild. So that's another really key thing about diagnosing monogenic diabetes, removing them from the type 1 and type 2 population. Their risks are different. They don't get the same complications in the same way because their background disease pathology is different. He talks about 7 out of 12 diabetics under the age of 30 having a mean duration of diabetes of 37 years. In the 1970s, that's unheard of. It's really weird. So he noticed this in this family. So this is what MODY is. It's a form of diabetes that does not clinically behave like type 1 or type 2 diabetes. It's autosomal dominant. It is less severe than type 1 and type 2 diabetes usually, and often doesn't need insulin. So unlike lots of the other talks you've probably heard where someone gets a really expensive drug or needs really expensive genetic testing, one of our main interventions after the relatively cheap genetic testing is taking people off insulin and giving them some really cheap drugs that work better than insulin. So they are sulfonylureas. So it's an odd condition that actually it responds to a very old-fashioned, really cheap drug. This sentence up here is about some of you don't see a lot of people with type 1 diabetes. We have a trio of antibody tests that help you work out if the patient has pancreatic destruction secondary to autoantibodies. Each of them are quite specific, but amongst them, if you test the three together, you get a much higher degree of sensitivity and specificity. All labs across the region will let you send those genetic those antibody tests. One of the reasons we send them is to prove a patient doesn't have type 1 diabetes. So that's where that comes in, what you're trying to work out with the patient. So often in clinic, you're looking at the patient thinking, there's something not quite right about your diabetes, or they will then volunteer that they've got, all their siblings have been diagnosed with diabetes, half of them on tablets, half of them on insulin, they've got a grandma with diabetes, they've got a great aunt with diabetes. And it's at that point you start thinking, are you really a type 1, are you a type 2? Let's get some more information. So that's where those antibodies fit in. So this is a slightly busy slide. The most common forms of MODY are sort of at the top. The GCK MODY is an interesting type of diabetes, not really thought of as diabetes because it's not progressive. So we all release insulin when our blood glucose gets to a certain level. For some people that's 4.2, for some certain people it's 4.5, but it means that your insulin will track your blood sugar and your blood sugar won't go too high if you don't have diabetes. GCK people, the glucokinase gene, which is the gene that determines when you release insulin, instead of setting your insulin release to 4.1, 4.2, it sets your insulin release to 5.5 and 5.6. So these people always look like they've got an elevated glucose, but they will release insulin just at a higher level. It's like having your thermostat at home set to a higher temperature than someone else's house. They always have an elevated HbA1c, but because they release insulin normally, it's not a progressive condition. Whatever treatment you try and give them, they will buffer it to the same blood glucose. You don't treat them. So GCK is thought of as a non-diabetic condition. It's not progressive. They don't have any risks. So for those patients that we diagnose with GCK, we can take diabetes off their diagnosis. They don't have to go to retinal screening. They've got the same cardiovascular risk as other people, age matched for where they're from. You can take quite a lot of risk away. They do cause problems when they're pregnant, some of them. The bunch in red in the middle are transcription factor abnormalities. So they're all involved in either the beta cell itself or somewhere in pancreas or renal development. HNF1 alpha is really common. HNF4 alpha is a bit less common and very weird. because people tend to express it predominantly in utero, in the perinatal period, and then later on in adolescence. And the HNF4 alpha people overexpress this gene in utero, so they develop hyperinsulinemia. And whether they have diabetes or their parent has diabetes or not, they're all really big babies who suffer from neonatal hypoglycemia. So if you know a family's got HNF4 alpha and the dad or the mum, and they're about to have a child, you have to watch out for that risk. So those people need to get referred to a specific obstetric clinic. They need to have neonatal beds planned. The neonatal hypoglycemia is unavoidable, and that baby needs to be looked after. It wears off after a few days. The HNF1 beta people have renal cysts that appear before their diabetes. So for the majority of these conditions, people present in adolescence, and it can get progressively worse. But the HNF1 beta people have renal cysts in utero, and then their diabetes appears in adolescence. And they have a number of other genitourinary problems and some neurodevelopmental issues as well. Small population. People at the bottom are slightly different. They have neonatal diabetes, which I've just said type 1 presents as an autoimmune condition. Babies don't have a well-functioning immune system. So if you develop diabetes before 6 months of age, you're likely to have one of these. If you talk to families that have a family member with neonatal diabetes, I've got 2 or 3 families, it's awful trying to manage a baby with insulin. That child is really sick. But if you are diagnosed with diabetes before 6 months, those babies can be managed on glycoside, not insulin, and usually not very much, and it basically normalizes that baby's physiology. So although these are all dramatic, a lot of them are related to beta cell issues, and other than GCK, the majority of them can be managed with sulfonylurea, so glycoside, glibenclamide, glimepiride, really cheap from the 1950s. But they work, although they work in really unusual doses. So my neonatal diabetic patient is on 5 times the normal standard maximum dose of glyphosate, but she's fine. She's got insulin. Interestingly, she married someone who owns a haulage company, and because she was on insulin until her neonatal diabetes, she couldn't drive HGVs, but now she can because she's off insulin. So make a difference to the patient's life. Obviously, she doesn't have to inject herself all the time. However, recently she's had breast cancer, was put on loads of steroids, and had to go onto insulin temporarily because the glycoside wasn't enough for that patient. So the things that I've said already. Monogenic diabetes is supposed to account for 3.6% of all diabetes diagnosed in the age of 30 years. In adult care, the majority of our patients are diagnosed in their 40s and 50s. Pediatric care, all of your patients are in this bracket. But my sort of understanding of paediatricians is that the type 1s behave in such a specific way, these people tend to pop out a bit more, and they are good at getting the testing done. Monogenic diabetes is misdiagnosed in 80% of cases. So it's you get the fact the patient has an abnormal glucose and you decide they're type 1 or type 2 and you don't think about it again, which we shouldn't do. And there's a widespread variation in case identification across the UK, which I'll show you on a later slide. I've mentioned the other 2 things already. So this is a slide from 2015. This is data from Exeter, where they looked at the kind of incidence of what they think monogenic diabetes should be, and how many cases you've identified for your population. So we're this line in red, our population, 7 million and something, expected to have 767 monogenic cases, but we only have 116. So we are missing cases. We're not the worst at missing, but we're not the greatest. We're not great at trying to get these people out of the population. So this was in 2015. After 2015, so in 2015, 2016, we did have a genetic diabetes nurse appointed called Peter Naveen. I don't know if anyone ever had anything to do with Peter. So she was there for the whole of the Northwest. If you wanted to diagnose someone and weren't sure what test to do, you could contact her. If you had multiple family members spread across the Northwest, you'd go to their houses, get blood, get them tested, or get their GPs involved. She'd titrate medication, she'd take people off insulin. But after she retired in 2019, her funding wasn't renewed from Exeter. But she did, so in her first 2 years, she identified 100 people with monogenic diabetes. So it's useful having somebody who knows just that little bit more. Was useful. So the new model of MODI management is not to have a genetic diabetes nurse. It's to try and upskill diabetes healthcare professionals. So adult nurses and doctors, pediatric nurses and doctors, upskill the genetics team so they kind of know what we're doing, and also obstetric teams, because some of these patients cause problems in obstetric management. Exeter already offered at this stage a really, really good education programme, because healthcare professionals just get confused with monogenic diabetes. In a busy clinic, they tend to not think about it. We already ran an education programme. The national strategy was trying to get, the first step was to try and get as many people comfortable with monogenic diabetes management, to identify a lead doctor and nurse per trust across your region, and then look to see if that impacted on referrals. The first step was educate people. Second step was identify some leads to take some responsibility over it in your department, and then look to see if that improves management. So in the first year, 120 people, so this is all national data that we had to collect. 120 people were educated. This is during COVID. This was all launched in the middle of 2020. The healthcare professionals, mainly in adult care, so 120, 76%, but adult care teams are massive, and 23% was paediatric. This shows you who was trained whom. So Warrington does have a few. I think you're at the end, alphabetical, I do apologise. It looks like MFT's gone a bit mental, but they are a really big trust with a big paediatric unit. But most teams are asked to train 2 or 3 more people, which is a lot, I think, in the climate where we were in 2020. What this looked like in terms of training and identifying leads was quite good. So 84% of the trusts across our region had a MODI trained staff member. That's really good. 100% of trusts volunteered a consultant to be responsible for MODI management in their trust. Can't see the nursing one, it's 80 something. As a nurse who was trained, who you could go to for queries and who would lead on it. So the North West did really, really well, coming from a baseline of we weren't doing well. And then the impact, so this is national data looking at referral trends across the first and second half of 2021. So nationally, 20% is quoted as what you should expect for your pickup rate. So again, as a clinician, both diabetes nurses and doctors, I think everyone feels a bit disappointed when you send someone off for testing. It's difficult to diagnose. So the nationally expected pickup rate is 20%. And you can see the number of referrals nationally has gone up quite a lot in monogenic diabetes land, and the pickup rate didn't drop. The family member pickup rate, you can see, is much higher, as you would expect. And the aim is, once you've identified monogenic diabetes in your programme, is to look through their family history to test for the same type of monogenic diabetes, every diabetic family member. And this is the number of referrals made across the North West here. This is, again, it's a good number for a trust of your size. We're going to ignore MFT, they've gone crazy. But you can see that most people are testing someone, and this is just for 2 quarters, so it's for half a year. Our diabetic populations are relatively big, and it's sometimes difficult to identify these patients in clinics. It's pretty good. The first step is to actually make the referral. The other big change that's made referring more patients easier is we go to before 2020, your trust or the patient's GP had to pay for the genetic testing. For the simplest test, that was £440. If you do a bigger panel, so you can either test for one monogenic diabetes type, or you can ask for them to sequence for all of the monogenic diabetes types if you're not sure which subtype they are. The second panel is about £800, and it's the big amount. You've sent someone for testing, your clinical manager will side along to you going, why have you spent so much money? In 2020, NHS England made the funding central, so you didn't have to have that argument, stroke fight, stroke concern in your department about getting the testing funded, which is a massive barrier in some trusts, thinking, where is this money going to come from? Small amounts of money. So this is good for our region. Some trusts are managing to refer very many people. They are the smaller trusts, and there are some trusts that don't have a very well structured diabetes department. Usually, so 76 referrals in that half year, which is really good. Bear in mind, we only had 100 totally known people with monogenic diabetes in 2020. In 2015, referring 17, getting a pickup rate close to 20% is really good. So the other thing that we've done, so part of what I had to do was find people across each trust to volunteer themselves to be leads, to publicise all the education that was going on, and to make sure people were getting trained. We also asked people in lots of different trusts what they think would be helpful for them. What will help you diagnose this condition? What will make things easier and better for you and your patients? So these are different things that we did. So the top one is like a quick guide to the tests you need to send, where you send them, links to the Exeter genetic site, which has lots more information on it. Another really key thing that was found was that although you may diagnose it in paediatrics or in adult care, because across our patch, there are quite a lot of standalone trusts, you're lucky in that you're all in one trust. Trying to find someone to test an adult in the paediatric service was a bit of a nightmare for those services. And in my adult service, if someone says they've got a 15-year-old that they want testing, I cannot do that because I can't take with little children in my trust. So this, I think we're the only region nationally who organised ourselves around embedding clinical genetics to help us work out who to test, to counsel families. Again, I can't counsel a 12-year-old, but a 12-year-old might want to find some information about genetic diabetes out if their parents got it, or their parents may be keen for them to get more information. And clinical genetics can help with that. And then our other difference between the other regions is we are quite populous with a lot of hospitals that are close together, which means that family members can be from a different, they may only be 15 miles away, but they'll belong to a different trust and you might not be able to test them because it's just logistically difficult. And clinical genetics can help with that, work out who needs to get tested and where the best place for them to be tested. GPs cannot do the monogenic diabetes screen, so they cannot get referred into secondary care. But they should be, because counselling someone about what you're testing them for and why is not entirely straightforward. The top corner is about testing for monogenic diabetes in antenatal care. So in South Manchester, they've embedded in their normal booking, the booking visit, if you've not had a baby, conscious that this is not everyone here has had a baby, but the booking visit is the longest medical visit in the world, where a midwife asks you 4,000 questions to work out all of your risks in pregnancy. And in South Manchester, they've embedded, does anyone in your family have monogenic diabetes, which is useful. Some of the problems that are caused in pregnancy are caused by the dad having monogenic diabetes, and maternal, that's a bit of a weird thing for maternal services to think about, but they've embedded that in South Manchester, and we're just waiting to see how much of an impact that might have. And the last bit is the GMSA website, which has lots of this information on it already, and newsletters, links to where you can go for learning. So that is monogenic diabetes management in the Northwest. Key things are, think about it in your patient, and also if you've got a patient with it, think about the rest of their family, because they will need testing too, and that's the thing that we've not done so well so far. Thank you.